Chapter 30 covers the non-infectious lower respiratory problems for adults. This covers outcomes 27 through 39. And be sure to watch the videos that I placed on Moodle. Those will help a lot. In this chapter, we're talking about asthma, COPD, including chronic bronchitis and emphysema, and then some other things such as cystic fibrosis, chest tubes, and pulmonary cancers. I want you to look at 549 and figure 30-1. It talks about chronic airflow limitation diseases, and it differentiates between asthma, emphysema, and chronic bronchitis. And remember, I said you would need to distinguish between the three, so I would start there. That'd be a good place. Asthma is huge and growing in our country, and we're unsure if it's related to allergens within the air or the number of people who are smoking or just genetics in general. But 20 million Americans have asthma and 300 million people worldwide. We see it more in women than men and slightly more in African Americans than Caucasians. The number of people with asthma, as I said, is continuing to grow. But again, we're not exactly sure why. So the two things that you should recognize in relation to asthma are inflammation of the airways, okay, and hyperresponsiveness leading to bronchoconstriction. And remember, I mentioned in class that the inflammation that we see today is actually cumulative. It's in relation to the exposures that have occurred over the past 7 days, according to the latest research. And of course, this picture is much better than what I drew on the board, but on the left here you have a normal bronchial tube, alveoli, and see how you have this nice open pathway here for air to go through. That's the lumen. And on the right you have an asthma episode, so the asthmatic disease, and you see with the edema and the mucus and the swelling how restricted and constricted that is. So we have inflammation and the hyperresponsiveness or the bronchoconstriction. Okay, so what differentiates asthma from COPD and chronic bronchitis and emphysema is asthma is considered to be intermittent and reversible versus COPD is chronic obstructive, right? So chronic, it's always there. There's always going to be some degree of disease versus asthmatics, especially people who are well controlled, oftentimes have days where they have no symptoms at all. The cause of the asthma attack, meaning the episode of reactivity, is usually specific to the person, so whatever the allergens are that trigger the reaction in that person. So it could be irritants, microorganisms, even aspirin, and we've talked about the asthma triad before, where people have an aspirin allergy and they get bronchoconstriction, specifically with the use of aspirin and other NSAIDs. Cold air can do this exercise. So people need to know their triggers. And then sometimes it's unknown, but people need to know their triggers. A lot of times this time of year, people start with an upper respiratory tract infection, and then those little microorganisms migrate down and cause inflammation of the lower airways, and then people end up with acute bronchitis and asthma exacerbation. So you want to do a really good respiratory assessment, right? Listen to all the lung sounds, look at the work of breathing, the rate of breathing, look for any signs of fatigue, Remember, in the history, you want to ask about intubations, and you want to ask about admissions to the ICU and ER visits, because the greater the number of ER visits, ICU admissions, and intubations, the sicker this person is, and the more likely it is that they won't do well during this visit if they're, coming to you emergently with an asthma attack. If they're just seeing you in the outpatient setting, for a routine follow-up, then you really need to make sure that they're well managed if they have a history of recurrent ER visits. So things that would show you that they're not doing well: wheezing, tachypnea, coughing, even if it's not productive. So there is what's called a cough variant asthma, so people who don't wheeze but they just have this tight cough. And so basically they're so tight that they aren't producing wheezes, but they just have this very constricted cough. So coughing would be a concern in an asthmatic. Use of accessory muscles, the barrel chest from air trapping, and remember that's going to be more of our emphysema client. A long breathing cycle. So what does that mean to you? And you need to know normal patterns of inhalation and exhalation, right? And those change as the person gets sicker and sicker, right? So normally, let's see, looking to see what page it's on, because I was just gabbing and not following along in the book. I'll find it. But normally we inhale faster than we exhale, right? Because it's easy to get air in because it's an active process, and then exhalation is a passive process, and it just takes longer to exhale. And with somebody that has narrowing and constriction, the inhalation phase is longer, and then if they get air trapping, the exhalation phase can change as well. So you want to look for changes in the inhalation and exhalation ratios. So their breathing cycle becomes longer. Cyanosis, obviously late sign, and then hypoxemia, also late sign. And remember, if they're hypoxic, they're also hypercarbic, and we're really more concerned with hypercarbia than we are with hypoxia, but our books just haven't caught up yet with those terms. So I'm really more worried about the fact that I'm trapping CO2 than the fact that I'm a little low on oxygen, because I'll do okay with a slightly low oxygen for a while, but I'm not going to do okay with elevated CO2 for any long period of time. Okay, so just to add to what I had said in that last slide, the normal inspiratory to expiratory ratio for people is 1 to 2. So it takes twice as long to exhale as inhale, because remember, inhalation is active, exhalation is passive. But in the asthmatic, even though inspiration might take a little bit longer because they're working harder, expiratory phase becomes prolonged. So it can end up being like 1 to 3 or even 1 to 4. So even though the 1 becomes longer, it takes even longer and longer, like 3 to 4 times longer, to exhale the air. So overall, the length of the respiratory cycle becomes much, much longer. And that's on 552 in your book. It doesn't give you the ratios, the 1 to 2, but it just says that the breathing cycle is longer with prolonged exhalation and requires more effort. So that's what they're talking about, is that normally it takes twice as long to exhale, and now it can take up to 3 to 4 times as long to exhale as air starts to get trapped. Lab values and things that we might assess while we're looking at the asthmatic client. So arterial blood gases, right? So the oxygen may decrease in the acute asthma attack because they're having a hard time exchanging gases. So we might see a decreased PaO2. And arterial CO2 may decrease early in the attack, and then because they're breathing faster, and then increase later, indicating poor gas exchange. So very early on, initially, you're going to have a small decrease in PaCO2, and then as the gas exchange worsens, you're going to have a rise, and then you're going to have an increase in PaCO2. And if that doesn't make sense, ask me, but that's an important concept. So they feel short of breath, they start hyperventilating, they blow off some of that CO2, but then as their airways constrict even more, they can no longer exchange gases, and so they get air trapping, and then that CO2 increases. If it's allergic response, then the inflammatory and allergic responses occur throughout the entire body. So on blood work, you'll see eosinophils elevated and IgE levels elevated. And remember, IgE goes along with epi, so that's the one that is like asthma, allergies, and anaphylaxis. If you did a sputum analysis, there would be eosinophils in the sputum. You get mucus plugs, so you get thickening and hardening of the mucus that's not mobile, because the person's breathing so much, they tend to dry out the mucus, and in those narrowed airways, they just make little plugs. And then epithelial cells are shedding from the lining of the mucous membranes. Okay, so we would do arterial blood gases. We would do some blood work, right? We might do a full CBC, but specifically we'd be looking at the eosinophils, and then we'd have to do a special test for IgE, and then we could do a sputum analysis as well. So on page 510, on table 27-6 are the characteristics and purposes of the different pulmonary function tests. And the ones that are most useful with spirometry and the asthma attack are the FVC, which is the forced vital capacity, and that's the maximum amount of air that can be exhaled as quickly as possible after maximum inspiration. So you have the person take a deep breath in and then blow as hard and fast as they can, and that's really very similar to a peak flow. Okay, so it's a breath in and then a breath out. Okay, the FEV1 is the forced expiratory volume in the first second, and that's the maximum amount of air that's exhaled in the very first second of expiration. And that's the cool thing with these machines, is that they're monitoring volumes and pressures and rates. So the machine actually calculates how much volume comes out in that very first second, so that kind of shows you air trapping. And then the peak expiratory flow rate, and that's telling you, I'm just looking to see, I'm not even sure that that one's on here. That one's not even on there, but the peak expiratory flow rate is telling you the strongest flow rate, like yeah, the peak part of it. So as you're breathing out, what the peak part of it is. So what's the strongest flow? So if there's a decrease in any of these, of 15 to 20% below the expected value or below the person's normal range, then they think, okay, they probably have asthma. And then remember, I said they treat them with bronchodilators, so they give them medicine and then repeat the test. And if it increases by 12% or more with bronchodilators, then they're diagnosed with asthma. So review those pulmonary function tests. Okay, so we covered these in pharm, but drug therapy is based on what's going on. So asthmatics who are just allergy induced sometimes just take like an over-the-counter allergy medication and then a reliever drug, which would be like a rescue drug, rescue inhaler. as needed. People who have more severe forms of asthma oftentimes need control therapy, and those alter the responsiveness or that inflammatory responsiveness of the airways, and they get used every day regardless of symptoms. So even if they feel like they haven't had an asthma attack in a long time and they're well controlled, that means the drug is working and they should stay on them. So the short-acting beta-2 agonists like albuterol, Xopenex, those are really our rescue inhalers. Epinephrine would be an intramuscular rescue drug, and then technically diluted IV epinephrine as a last-ditch effort could be used, but that's really just mostly for kids and only if nothing else is working. And then for adults we use theophylline if we have to IV as a rescue drug if epinephrine didn't work. So we went over the rest of these in pharm, but the rest of these are going to be preventative. And just remember that the cholinergic ones like Atrovent, which is ipratropium, are not rescue inhalers, right? So one of the things that's really interesting about especially allergy-induced asthma is that one of the treatments for that is exercise, and it's exercise outside. So Dr. Ghosh, Manindra Ghosh, who runs the allergy clinic at SVMC, does some really interesting teaching about this, but he said that the best treatment for somebody who has allergy-induced asthma is to get outside and do aerobic exercise outside, because that actually does the most to promote ventilation, perfusion, and actually improve oxygenation and ventilation, which is pretty cool. Kind of is almost counterintuitive. And then if the person is having an acute asthma attack, oxygen therapy to maintain a SAT of 92 to 99%, and neb treatments as needed. So a worst case scenario, you could have something called status asthmaticus, which is where you can't break the asthma attack status. Almost think of that meaning like stuck in. So they're stuck in their asthma attack, and the airway is swollen. The person can't breathe. You may have such severe wheezing that the chest becomes completely silent. So normally you have normal sounds on inspiration and wheezing on expiration, and then as it gets worse you have wheezing on inspiration and expiration. As it gets even more worse, you have wheezing on inspiration and silence on expiration, and then as it, the person's getting ready to die, you have what's called silent chest, where you're starting to see that seesaw, that they're not moving enough air to even create lung sounds, and that's really scary. And if you give somebody a nebulizer treatment, a couple things can happen. One, they can get better and their wheezes can get louder because you've opened the airway. Or two, they can get better and their wheezes can lessen because you've opened the airway. So it depends on how sick they were when you first gave them the treatment. The other thing that can happen is they're so sick that they're not moving the air and they're not getting the treatment in there, and so the wheezes can get louder because they're getting worse. Or two, the wheezes get softer because they're getting worse and they're moving towards that silent chest. So you can't just base your decision on whether or not somebody's getting better or worse on lung sounds. You have to look at that whole picture. What's their work of breathing? What's their mental status? Are they starting to have any accessory muscle use? Are they looking fatigued? What's their O2 sat and their CO2 levels doing? Is the O2 dropping? Is the CO2 rising? So put all those critical thinking pieces together. Don't just give someone a neb, listen to their lungs, say, oh, I don't hear wheezing anymore, they must be better. That's not necessarily true. That could mean that they're trying to die on you, and we don't want to miss that when it happens. Okay, so status asthmaticus intensifies usually fairly quickly. It doesn't respond to common therapy. Think of it as anaphylaxis within the lungs. the person can degrade very, very rapidly, even to the point of developing a pneumothorax and then going into cardiac and or respiratory arrest. So we give fluids, we give a systemic bronchodilator, steroids, epinephrine, and oxygen. So most of our meds for this person are going to be IV because they're not moving enough air to be able to hit the target organ with a breathing treatment. And hopefully that makes sense, right? So if they're so sick that they can't move enough air to get the med in, then giving them an inhaler or nebulizer treatment is not going to make them better. It's just going to prolong the time until you start using the effective treatment. So just hit them right away with IV fluids, IV meds, and hopefully that will get them better. Okay, so that was asthma. Now let's talk about COPD. So COPD is also a chronic airflow limitation problem, but now the difference is that it's not reversible. So whereas asthma was reversible and it was treatable, this is a non-reversible disease process that over time increases in severity and will eventually lead to respiratory failure. And COPD is broken down into two types, emphysema and chronic bronchitis, and both have some degree of bronchospasm and shortness of breath. Emphysema specifically, so we're going to talk about the worst kind. So really chronic bronchitis occurs first and then progresses usually into emphysema. But emphysema is the end stage or the worst part of COPD. And this is where you have loss of lung elasticity. And you can read in your book, this is on 557, it talks about the fact that normally in the healthy lung tissue we have an enzyme called protease, and that breaks down any particulates, organisms that are inhaled during breathing. So remember, the purpose of your nose is to warm, humidify, and filter, but other things make it down in there. So like when you're talking, you breathe through your mouth, or if you're smoking, you breathe through your mouth, or if you're eating, you often breathe through your mouth. So other things make it down into your lungs. And so the proteases will eat up those little germs or bugs or whatever, dirt, and dispose of them. In somebody who is like a chronic smoker or who works in an environment with chronic irritation, the proteases multiply. They have to get so many of them that they actually end up in this high level of proteases, they actually end up damaging the alveoli and the small airways because they break down the elastin or the stretchiness in the alveolar walls and in the bronchioles. And so then the alveolar sacs lose their elasticity. Some become narrow and collapse, and so that would be atelectasis, and then some become large and flabby, and they stretch and just become these air-filled, basically bubbles that really don't exchange gas very well, and those are called bullae. That's B-U-L-L-A-E right here. So bullae and atelectasis are kind of opposite. Atelectasis is a collapsing of the alveolar wall, and bullae is an enlargement and almost like a ballooning of the alveolar sacs. So if you almost go back to cardiology and think about, we can have hypertrophy versus stretching and thinning of the wall. The bullae would be that stretching and thinning of the wall. All right, and then we have the collapse of the small airways, the bronchioles, and atelectasis then of the alveoli distal to the collapsed bronchioles. So really, if you think about it, if you have a normal lung on this side and it has all these alveoli over here that are getting air and they're all happy, and then on this side, say we had emphysema, what happens is you have a space, let's say this space down here, where you have some bronchioles that have collapsed and you have some bullae, and you don't have any perfusion anymore to that area. So you may still have blood flow to that area, but you don't have any gas exchange. So really now you've lost a significant portion of your lung. It's almost like having a pneumothorax in essence, because you have this this large section of your lung that no longer can exchange gases. So your CO2 is going to rise and your O2 is going to decrease. So in contrast to emphysema, bronchitis is an inflammation of the upper bronchi and the bronchioles, rather than the terminal bronchioles and the alveoli, which we see in emphysema. So bronchitis is the earlier stages, it affects the larger airways. Emphysema is the later stages, it affects the smallest airways in the alveoli, right, because it affects the ends of the lungs. So bronchitis is almost always caused by chronic exposure to things like cigarette smoke or work environment, so a terrible irritant work environment. And so they get this inflammation, vasodilation, which causes edema and congestion of the mucous membranes, and then that causes a lot of edema and excess mucus production in the airways. And so that's why it's called chronic bronchitis, is because the bronchi are inflamed, but they also put off tons and tons of this thick, nasty mucus, which is often discolored because of the irritants like the smoke that caused it to occur in the first place. It affects the airways, not the alveoli, right? So we're talking about the bigger tubes. It's affecting the main stem bronchi and then some of the primary bronchioles, rather than the terminal bronchioles and the alveoli that get affected with emphysema. So asthma is reversible, very similar to chronic bronchitis, but just, short term and not really producing large amounts of thick mucus, but it's, inflammation and bronchoconstriction. And then chronic bronchitis is a chronic inflammation, vasodilation, congestion, mucosal edema, bronchospasm, thick, nasty mucus, right? So these guys have a problem with gas exchange, and a lot of times they're also overweight. So we call them our blue bloaters, because a lot of times they have cyanotic disease and they'll start to develop clubbing in the later stages. And then remember, with our emphysemic clients, we call them the pink puffers, because they have to peep themselves with pursed lip breathing, and they have the increased red blood cell count from the chronic hypoxia. So as the disease progresses, there are a lot of complications that can occur from COPD. The primary ones have to do with gas exchange and the limitation of the airflow and the inability to clear mucus correctly. So hypoxia and acidosis occur because the patient can't exchange the gases, right? So they're going to decrease the amount of oxygen in the blood, which is then going to decrease the amount of tissue perfusion. So we're going to have tissue hypoxia, or anoxia, meaning no oxygen at all. And then acidosis is going to occur because we're going to have a buildup of carbon dioxide in the blood. And those two things are going to make it hard for the rest of the body to function normally. So you can have confusion, you can have cardiac problems, you have poor tissue healing, you have poor muscle function. Just think about all of the things that can go wrong, like GI, metabolism, everything does not function well when the acid-base balance is off. Because they can't expectorate well, bacterial infections are very common, and the inflammation and the thick mucus make it even worse, because then it kind of traps it, and when they get sick, they get incredibly short of breath quickly, and they're very difficult to treat, especially patients with end-stage COPD. So it's important to teach them about respiratory hygiene and etiquette, and to get seen immediately if they start to feel ill. Cardiac failure, so especially right-sided heart failure, which is called cor pulmonale, and that's it. Cor pulmonale is right-sided heart failure related to pulmonary disease, occurs with bronchitis and emphysema. and so they get air trapping, that airway collapse. The alveolar walls are very, very stiff, and it increases the lung tissue pressure and narrow vessels. So it essentially creates a pulmonary hypertension environment that the right side of the heart has to work against, and then the right side of the heart starts to fail, and then it backs up into the body. And so that looks very similar to just your typical right-sided heart failure. So they have hypoxemia, which causes hypoxia. They are short of breath, especially with exertion. They're fatigued. They have hepatomegaly, splenomegaly, jugular vein distension, hepatojugular reflex. Their hands and feet are warm and cyanotic with bounding pulses. Their lips, they have like circumoral cyanosis. On EKG or echocardiogram or chest x-ray, you might notice a right ventricular enlargement or hypertrophy. If they're thin and you have them lay back, you might actually be able to see the right ventricle pulsating below the sternum. So if you look at the xiphoid process, right, the sternal notch right at the bottom, you might be able to actually see the bottom of the heart pulsating up against the diaphragm. They have GI things like nausea, anorexia, peripheral dependent edema, metabolic and respiratory acidosis, and pulmonary hypertension. So, essentially, cor pulmonalis is pretty terrible to have. It's one of the horrible things that ends up killing our end-stage emphysemic patients. And then cardiac dysrhythmias. So cardiac dysrhythmias are also very common. So remember, we're existing now in an acidotic environment. Our acid base is off. We have kind of a chronic hypoxia going on. It makes the myocardium very irritable, and it causes all sorts of ventricular dysrhythmias and atrial dysrhythmias. So they get something called multifocal atrial tachycardia, and then they're also more at risk for ventricular dysrhythmias like PVCs, ventricular tachycardia, and then ventricular fibrillation and arrest. So on a good bad scale, Crystal, all of these are bad. So I'd like to have you look at page 560 in your textbook, which is a concept map about COPD. And this is fabulous. This is about Nick Williams, who's 66 years old, longtime smoker, admitted with exacerbation of COPD. He's short of breath, and he has a cough that's productive for thick yellow mucus. Okay, it gives you his blood gas, his lab values, it gives you his overall problem list, it sets some expected outcomes, and then it goes through his history, physical exam, his nursing priorities, the lab assessment, the drug therapies, and the psychosocial assessment. So I would really take a look at that. I think that that's fabulous the way that they have that laid out. And I also think that if you're a visual learner, reading through that might really help you understand your priorities in terms of caring for the patient with a chronic obstructive pulmonary disease. On page 561, you can see this cute little dyspnea assessment guide, very similar to the analog pain scale. The patient just rates, like, do you feel shortness of breath as bad as it could be? And they can, draw, sometimes they're marked with numbers like 1 through 5 or 1 through 10, and sometimes they just point to a part on the line, and then you kind of mark, that they're halfway, a quarter of the way, 3/4 of the way. Right below that on 561, you see clubbing as well, which is an excellent picture of clubbing. So for the lab assessment for the patient with COPD, you are going to look at serial ABGs, so over and over to look for changes in acid-base status. And as the person worsens, the O2 is going to drop, right? So we're going to look for decreases in O2. All right. Initially, remember that the CO2 might actually drop, especially in patients with chronic bronchitis, if they are breathing rapidly. And then as they get worse, as they're approaching respiratory failure, the CO2 will elevate. Now, chronic CO2 elevation, sorry, my dog is just going nuts today. Chronic CO2 elevation, CO2, you can't even read what I'm writing. Chronically elevated CO2 is really only seen with emphysema, because emphysema is the one where we have damage to the alveoli. So at baseline, patients with emphysema are going to have chronically elevated CO2. Now remember, I was talking about 2% of our COPD patients are going to have true hypoxic drives, and on ABG, they're going to have that elevated CO2. They're going to have destroyed the hypercarbic sensors. They're toxic, right? And instead, they're going to breathe based on their O2 levels. So you're looking for that also on ABG. Again, we can check sputum samples, we can check CBCs, H&H. Now remember, with our emphysema clients, we expect our H&H to be higher. So it's polycythemia, but not polycythemia vera. Polycythemia vera is a disease. Polycythemia is just the condition of having more red blood cells than normal, right? So that's a compensatory increase in the red blood cells and iron in the chronically hypoxic patient. So the kidneys say, we don't have enough oxygen. They secrete the erythropoietin. They tell the bones to make more red blood cells. You make more red blood cells. The person is, hemoconcentrated, so they have a high number of cells per deciliter in the blood, and it's because the body is trying to figure out a way to carry more oxygen. Okay, we look at electrolytes, and then our other, we can do testing, so you can look to see if they have any sort of genetic markers for COPD. Chest x-ray will show us infection, it will show us spacing, it will show us the bullae or the atelectasis or enlargement of the heart, and then pulmonary function tests, which we talked about. So our assessment, our diagnostic assessments very much are specific to the respiratory tract and to looking at whether or not there's been any compensation, right? So the chronic elevation of the CO2, the hypoxia, the increase in the H&H, all of those would point towards emphysema. So the interventions for a patient with COPD are covered on 562, 563, 564, 565, and into 566. And I'm going to skim through them. I would suggest that you read them carefully. I think that, first of all, they're really important, but in clinical, these would be the things that I would expect to see you do. All right, so the first one, improve oxygenation and reduce carbon dioxide retention. So now we're talking about oxygenation, respiration, ventilation. So remember I was talking about less than 2% of the population truly have that hypoxic drive. On 563, it talks about that, and it says all hypoxic patients, even those with COPD and hypercarbia, should receive oxygen therapy at rates appropriate to reduce hypoxia and bring SpO2 levels up between 88 and 92%. So remember, we are gauging our oxygen, so we're titrating to 88 to 92%. Now, a doctor might write very specific orders for this, but that's all we need, 88 to 92. We're not trying to make them 99 to 100. We're not trying to give them high flow. If they're in respiratory distress, we want to look for the ventilation problem, but if they're hypoxic, we want to titrate oxygen to 88 to 92%. Okay? You want to teach them things like diaphragmatic or abdominal breathing and pursed lip breathing, and the education component for that is on page 563, chart 30-10. And I'm going to have you read that rather than me reading it to you, because you can see the pictures and it makes more sense with the pictures. You should be able to teach this to somebody. Okay, I would expect in clinical that you could teach these to somebody who was newly diagnosed with COPD. Preventing weight loss, so we talked about this as well. Actually, hey, let me go back for 1 second. Suctioning. What did we say about suctioning? We only suction when needed, not on a routine schedule. We don't suction hourly. We don't suction every 2 hours. We only suction when needed. So if the patient has a really weak cough, weak muscles, they can't cough stuff out effectively, you might have to nasotracheal suction them, which means that we sterilely go up the nose down into the trachea and suction that way. But if they're coughing and they can get it up into like the hypopharynx, so like kind of behind the tongue, you can just use the Yankauer and suction it out that way. Okay, when you're suctioning, remember, limit your time, like no more than 10 to 15 seconds. You don't suction on the way in, you only suction on the way out. Be very, very careful. Don't stick the suction catheter, the rigid one, any place where you can't see it. Don't, suck up against like the tonsils or the back of the throat. And just be really careful about hypoxia during suctioning. Just, put it in, suction what you need to get, and then take it right back out again. Okay, just be careful with those because they can make the person gag, they can make the person vomit, and then we have a whole other problem. And then as far as mucus clearance goes, remember the 3 liters. So our goal is 3 liters of fluid a day unless they have fluid restrictions. And then if they have fluid restrictions, then we need to find out what the actual goal is for the day. But for most patients, our goal is 3 liters of fluid a day because that's going to really hydrate them. And some places in the book it says 2 to 3, so somewhere in that range. And then a humidified oxygen, if they're on oxygen, want to use that humidifier so that those secretions don't get too thick and don't turn into cement. Okay, so that should be it on oxygen. For the person for preventing weight loss, so we had talked about this a little bit. People with COPD have loss of smell, loss of taste. They don't have any appetite. They oftentimes have food intolerances, nausea, early satiety, so they feel full as soon as they start eating, and they get short of breath with eating because, remember, they can't time their respirations and the chewing and the swallowing. They need, to be in that tripod position to breathe, especially with end-stage COPD, end-stage emphysema patients. And so trying to time eating is very difficult for them. So some things that we can do, dyspnea management, 4 to 6 small meals a day. Don't have them try to sit down and eat like this huge, steak and potato and salad dinner. They should be eating small meals throughout the day. Okay, use the inhaler, the bronchodilator, 30 minutes before the meal to reduce bronchospasm. So if we know that they can use their albuterol puffer 4 times a day, then 30 minutes after they use that puffer, they should eat. This is really critical when you're in clinical too. If you have somebody who's pretty sick and they have, an 8 a.m. inhaler scheduled, we really want to get that inhaler done at 8 a.m. because they're going to get their breakfast at 8:30. And that's why the nebs come at 8 and noon, or 8 and 11:30 or whatever, so that they're getting nebbed right before lunch or right before breakfast and even right before dinner, because that way they're breathing the easiest when their foods come. And then help them pick out foods that are attractive to them, easy to chew, things that aren't too dry, and things that aren't gas forming. You should avoid caffeine-containing drinks, and because those can lead to dehydration, and anything that would cause bloating or feeling of fullness. Urge the patient to eat high-calorie, high-protein foods like we talked about, and then dietary supplements such as Pulmicare. And I found it on 565, Randy, so it is in the book, but you're right, you found the right one. Provide nutrition with reduced carbon dioxide production, which is meaning you're teaching these people about reducing their processed carbs, okay? Healthy whole grains are still okay, but the focus is we really want to get nutrient-dense proteins, high-calorie, high-protein foods, healthy fats, healthy proteins, and complex carbs in them. We really don't want to dump a lot of soft, easy to eat macaroni and cheese kind of things in them, because that's going to increase their carbon dioxide and it's going to really increase their work of breathing. Okay. Managing anxiety, we talked about. So having a plan is helpful. Having meds is helpful. Teaching them the pursed lip breathing, the diaphragmatic breathing, that's also helpful. And then getting them into a support group or teaching the family what to expect and what to do, also helpful. Some physicians are great at hooking patients up with someone who will teach them like guided imagery or meditation or biofeedback, so that they can help sedate themselves or calm themselves down. But some really need those benzodiazepines, some need the Ativan, and that's okay, right? I mean, if you think about it, when we reach this stage, this is palliative care. So just like the person who's dying of cancer and they're in pain, the person who is dying of emphysema is in anxiety, and we have to treat that as if this is a palliative measure. Okay, so don't be afraid of giving the benzos. Don't give too much. You don't want to suppress their respiratory rate, but definitely do treat that anxiety. That is that air hunger and that anxiety is very, very real, and it's terrifying. Okay, improving activity tolerance. So our goal is to get people out and walking, even if it's just 20 minutes a couple times a day. Sorry, not a day, geez, a couple times a week. That would be fabulous. And maybe you start at 5 and you build up. That's okay. But anything that we can do to help increase their activity tolerance is going to be great. So remember, energy conservation, you want to kind of stack all of your care together. So cluster as much as you can, schedule rest periods, schedule activity for after the nebs. So maybe it's neb, eat, rest, walk, right? Because you want that person to have the energy from the food and then a little bit of rest after eating and then some activity. Just work with people, whatever seems to work the best for that person. And then preventing infection is important as well. So we're always worried about pneumonia because of the mucus and because of the ineffective coughing. So we always want to teach people hand hygiene, respiratory etiquette, avoid crowds, get your pneumonia vaccine, get your flu vaccine, and report to your doctor as soon as you feel sick. Drug therapy for the chronic obstructive pulmonary diseases is no different than what we talked about in pharm, right? So we have our short-acting beta-adrenergic agonists, which are our rescue inhalers that are also used kind of prophylactically, sometimes like 4 times a day. That's fine. We have our long-acting that are used usually in conjunction with a steroid. We have our steroids separately. We have our cholinergic antagonists like our ipratropium, which is the Atrovent. The methylxanthines, again, oral theophylline, we don't see very much, but remember, if you do see it, you have to keep a careful eye on the blood levels. NSAIDs for pain, and then mucolytics, right? So something like Mucinex, which is guaifenesin, you could take as well, and that just helps make the cough more productive. But more important even than the mucolytic is the 3 liters of water a day, because if you take the mucolytic and you don't drink the water, you're not going to be able to cough out the nasty gunky stuff. That's a technical term, nasty gunky stuff. So back to an earlier chapter, we were talking about some of the surgical and assessment techniques for lungs. So a patient who has end-stage lung disease, whether it's cancer or whether it's cystic fibrosis or emphysema, does have the option for a lung transplant. but they're very hard to come by. A complete set of lungs is hard to get from a donor. So for the emphysemic client, instead, a lot of times what they do is they go in and they remove those, the bullae, kind of like the little blebby areas. And they can do that either through bronchoscopy or through a sternotomy, or using what's called a VATS. And the VATS is the video-assisted thoracoscopic surgery. So basically they go in and they'll ventilate, so they'll intubate one side, so either the right or the left main stem bronchi, and they'll ventilate just that side, and then they'll completely deflate the other side of the lung, the other lung, which is kind of cool. And the bullae don't collapse. So the normal lung tissue collapses, the bullae does not collapse, and then they know where to cut, and so they just kind of take that area out. Post-operatively, though, if they had a sternotomy, then obviously we're looking for infection, bleeding, pain, respiratory distress, problems like that. If they just had a bronchoscopy, then we're looking for infection, bleeding, pain, but you know, most of it's going to be internal rather than a giant suture line and staples. So what they recommend for nursing interventions for post-operative care is close monitoring. You're looking for respiratory problems, so that would be, you know, hemoptysis, respiratory distress, so any increase in rate or effort, any decrease in oxygen level or increase in CO2, and then, you know, pain, bleeding, infection. Bronchodilator and mucolytic therapies are maintained, right, to keep those airways open. And sometimes, you know, if they're coughing, they would put them on an antitussive because we don't want them coughing after surgery, right? Pulmonary hygiene, so incentive spirometer 10 times per hour while awake. And if you have a patient who's non-compliant, remember you can just go in and listen to their lungs every hour, and that makes them take 10 deep breaths an hour. Chest physiotherapy, so that's like the, you know, clopping the, hitting your hands, you know, causing the vibrations on the chest wall. Of course, I'm doing it on my book and you can't see me, but on the chest wall to loosen the secretions so they can clear them better. And that starts on the first day after surgery. And hourly pulmonary assessment. So that's really critical, is that an hourly pulmonary assessment, and then reporting any signs of, you know, respiratory distress, bleeding, changes in vital signs, things like that. On page 566, there's a great home care assessment chart, 30-11, that talks about assessing respiratory status, cardiac status, and nutritional status for the patient with COPD at home. And that helps you assess their ability to be at home safely and how they're doing. Most patients with COPD are going to be at home until they're at that point where either they can't physically or cognitively manage either their medications or their oxygen on their own, or they're so fatigued that they can no longer do their ADLs on their own, or they have some comorbid problem like cardiovascular disease or something else that lands them in a long-term care facility. They might be hospitalized for acute exacerbations or infections, but the ultimate goal should get them maybe into rehab and then back home. We talked about oxygen and the requirements for oxygen at home. So teaching, you know, make sure when you're teaching that the person can actually use the medications that you're giving them in the form that you're giving them to them, teaching them about signs and symptoms of infection and to call early, breathing techniques and relaxation therapy. So all those things that we've already talked about. But basically, you know, you want to give them the tools that they need to be successful at home. And remember when you're teaching that you need to think not only what do I need to teach them, but how am I going to evaluate them in a way that I'm sure that they understand, and they're not just nodding and smiling and saying yes, but that they actually that they actually understand what it is, or they actually believe what it is that I'm telling them. So maybe they understand, but they're not buying into it, and then that's a whole other problem. So maybe have them write out, what their plan's going to be for the day, or start kind of collaborating together, like when their next appointments are, and writing on a calendar like all the things that they're going to do. And maybe that might help break it down into day by day instead of being so overwhelming. Kind of like, what I gave you on the first day of class, when I kind of broke down day by day when things were due, so that it wasn't so overwhelming looking at 60 pieces of paper. So moving on then from COPD, we're on page 567 in your book. We're talking about cystic fibrosis. And cystic fibrosis is a genetic disease. Okay. And normally the first signs of this are seen in early childhood. This has to do with chloride transport, and there's an error with chloride transport, which means that the mucus becomes incredibly thick and it plugs things up. So any mucous membranes throughout the entire body are going to create this very nasty, thicky, stick mucus and not bring water along with it. So we're talking about not just the respiratory tract, but also the pancreas, the liver, the salivary glands, and the testicles. And so the person not only then develops lung disease, but also atrophy and organ dysfunction in a lot of the non-pulmonary organs. So pancreatic insufficiency, malnutrition, intestinal obstructions, poor growth, sterility, and cirrhosis of the liver. And then because of other absorption problems and side effects, they oftentimes end up with osteoporosis and diabetes. However, the reason that we lump cystic fibrosis in as a respiratory issue rather than like maybe an endocrine issue is because that most people die from cystic fibrosis because of respiratory complications. So life expectancy when I was younger was in the teens, and now has really increased. They're living into their 30s and 40s, which is absolutely fabulous. Because we're more aggressive with treatment and therapy, and new meds and new treatments have come out. So just overall, cystic fibrosis looks like, when you make it to adulthood, the adults are usually smaller and thinner than average because they are overall malnourished because of absorption problems. A lot of times they have just a chronic abdominal distension. They might suffer from reflux disease, and because of the constipation, they might get rectal prolapse. Their stools are often gray and very chalky colored. They're like thick and chalky gray color, and foul smelling. And then steatorrhea means that they might have a lot of fat in their stools, excessive fat in the stools as well. And when that happens, then the stools float in the toilet. They experience a lot of vitamin deficiencies. Again, this is an absorption issue, especially the fat-soluble vitamins, so A, D, E, and K. And then diabetes, as I mentioned, because of the pancreas malfunction. And then osteoporosis because they're not absorbing vitamin D, which is needed to help with calcium and managing bone function. So what this looks like, and they're not going to make it to adulthood without diagnosis, but chronic respiratory infections, chronic chest congestion, exercise intolerance or activity intolerance, cough, and sputum production, use of accessory muscles, decreased pulmonary function, changes in the chest x-ray, and that they'll show infiltrates and an increased AP diameter because of a chronic increased work of breathing. So lung-wise, they start to look very much like an emphysemic person, but just much younger. It occurs much younger. The way that we treat our CF patients, as I said, has progressed a lot. On 568, you can see the vest that they use, and this does high-frequency chest wall oscillation. So this is chest physiotherapy, and it's absolutely fabulous. It basically, you put it on and it vibrates the mucus loose. It helps them clear it. In addition to that, we do nutritional therapy. So we try to maintain weight and vitamin supplementation, manage their blood sugars, and replace their pancreatic enzymes. So they take a lot of replacement medications. You want to teach them about drug therapy, infection prevention, pulmonary hygiene, nutrition, and vitamin supplementation. They'll have a very specific routine based on their individual needs. And then exercise. So we try pretty hard to encourage them to lead as normal life as possible, but you also want to not you don't want to baby them, I guess is the right word, right? So you want, when they're healthy, when they're normal, you want to increase lung function as much as possible, versus when they're sick, then they need to rest. So during an exacerbation, our goal is to avoid mechanical ventilation, okay? Because it's really, really hard to get them off the vent. Instead, we could do supplemental oxygen, or they could do the Heliox, which is 50% helium and 50% oxygen. And that just helps increase like the partial pressure of oxygen and push it across the alveolar membranes. It's pretty great. Airway clearance techniques, so we teach them, how to cough, and then respiratory therapy also can do like pulmonary hygiene, bronchodilators, mucolytics, fluids, and steroids as well. So all of that's great. In a lot of the hospitals, they can kind of check themselves in when they feel like they're getting sick, or when they feel like they're having increased work of breathing. They can just check themselves in rather than having to like go to the ER and be seen. But really, prevention is the key. So our goal really is in prevention, and we want to keep working with them on how to prevent those respiratory infections, because the longer that we can keep them infection free, the better they do. So there is some gene therapy available out there as well, and there's some oral drugs, which is kind of cool. So they're still experimenting with things, but just teach them hand washing, hygiene, respiratory etiquette, get their vaccines if they're allowed to be vaccinated, and that's it. Kind of try to prevent getting sick and notify their doctor as soon as possible if they do get sick. So as I had mentioned, similar to the emphysemic client, there is the option for transplantation. The cystic fibrosis client could get both a lung and or pancreatic transplant. This is not curative because the person still has the chloride transport problems, but it could extend their life by 10 to 20 years. They're still at risk for all the infections and at risk for rejecting the transplant. But for somebody who's living a productive life, and if they can find a match, an extra 10 to 20 years is fabulous, especially if they're living till 40 and then they can extend that out to 60. That's an extra 2/3 of their life, so that would be pretty amazing. Care is the same, right? So post-operatively, we're looking for pain, infection, and bleeding. You know, obviously respiratory assessment is going to be huge. And if they had a transplant, then they're going to have chest tubes and central lines and arterial lines. And then you're going to look for signs of rejection. They use anti-rejection drugs, so those are started immediately after surgery. And then steroids as well. And just remember that like the anti-rejection drugs and the steroids slow down the healing process and also increase the risk of infection. So some kind of last topics in your book. On 569 talks about pulmonary arterial hypertension. We talked a little bit about this with right-sided heart failure. But basically, there's you know, either a stricture or a spasm in the pulmonary vasculature, and you see this mostly between the ages of 20 and 40. Oftentimes, it's familial, so it's genetic. Usually, the person presents with dyspnea and fatigue, and then they develop right-sided heart failure from this. There's a couple drugs that we use. The calcium channel blockers have been used for this. Sometimes they get put on blood thinners, like Coumadin, to make sure that they don't get clots because the blood flow is decreased. And then recently we started using endothelin receptor agonists. And then natural and synthetic prostacyclin agents. And those basically just improve blood flow through the lungs. And they say that it also just, you know, overall helps prevent the need or the progression for surgery. There is surgical management, and that would be a lung transplantation. And if they have developed cor pulmonale, which remember is right-sided heart failure from pulmonary hypertension, then they would have to have both a heart and lung transplant. So you can read up about that. There's some different classes, and you know, the treatment for it is kind of interesting. So just something to keep in mind, if they are getting the IV prostacyclin agents, the drug therapy cannot be interrupted. And it should go in through a central line. Okay, so deaths have been reported if the drug delivery is interrupted even for a matter of minutes. Teach the patient to always have backup drug cassettes and battery packs. If these are not available and the line is disrupted, the patient should go to the emergency department immediately. So basically, if the pump stops functioning, the person could die within a matter of minutes because the drug wears off so quickly, the half-life is so short that those vessels will spasm again, and yeah, eventually they'll just essentially die, which is kind of sad. So we're just going to kind of draw a line there. So that's pulmonary arterial hypertension. Interstitial pulmonary diseases include the sarcoidosis, idiopathic pulmonary fibrosis, occupational pulmonary disease, which is kind of cool. All these. Sarcoidosis and idiopathic pulmonary fibrosis, not the occupational. I lied to you. Just those two. So these are fibrotic lung diseases. So basically they affect the alveoli, the blood vessels, and the surrounding support tissues of the lungs, but not the airways at all. They're restrictive, so they prevent good expansion and recoil of the gas exchange units, the little alveolar sacs, but they're not obstructive. So these are restrictive diseases rather than obstructive diseases. The lung tissue itself thickens, causing reduced gas exchange, and stiffens, but there's no air trapping because the tubes themselves, the bronchi and the bronchioles, are not affected. Does that make sense? So COPD is like an obstructive problem, but sarcoidosis and pulmonary fibrosis are restrictive problems. So sarcoidosis is just inflammation. They don't know why. It's non-cancerous, but it forms all these tumors, these granulomas in the lungs. Again, it can cause cor pulmonale, and the person presents very similar to having lung cancer, but the biopsies are negative. So they have cough, shortness of breath, abnormal chest x-ray, and then they make sure they biopsy it to make sure it's not an infection or cancer. A bronchoscopy is often used for that as well. And so we use steroids and then immune modulators like our chemo agents, even though it's not cancer, to help control the growth of the sarcoidosis. Idiopathic pulmonary fibrosis then is a little more common, and it's found more in people who have exposure to irritants like cigarette smoke, inhaled irritants, or even amiodarone. So that's kind of interesting that somebody who's been on a disease for their heart for a long period of time might develop pulmonary fibrosis. Essentially they have a lung injury from the irritation, and then when the cells start to heal, they form fibrotic tissue that thickens the alveoli again, and doesn't allow for normal gas exchange. So on both of these, the progression is kind of slow. With pulmonary fibrosis, the CAT scan shows this really cool honeycomb pattern where it actually looks like they have a honeycomb in their lungs, in the affected lung tissue. It's actually really interesting. You can Google that. Google the honeycomb CT lung scan. So again, steroids and immunosuppressants just to help slow it down and stop it. And then the person still may progress, but hopefully we slow down the progression of the disease. Occupational pulmonary disease, very similar, but we know that it comes from occupational exposure to environmental fumes, dust, vapors, gases, bacteria, fungal antigens, and allergens. And this could even just be like mold and things like that are in the workplace. They get made worse, obviously, by cigarette smoking, and so smoking cessation efforts are important. Depending on the agent or what's causing it, the manifestation will be different. So if you look at 573, chart 30-2, it talks about asthma, pneumoconiosis, diffuse interstitial fibrosis, and extrinsic allergic alveolitis. So there's some different ones on there that you can look at, but just know that know that it will the presentation will change based on the organism that's irritating them. And then lastly, lung cancer. So lung cancer is the leading cause of cancer-related death worldwide. In America, pretty much all the other cancers combined don't add up to lung cancer. There's about 228,000 new cases a year, and then 160,000 deaths each year just from lung cancer. Once diagnosed, the likelihood that you'll make it to 5 years is less than 20%. It's pretty sad. So the prognosis just remains poor, even if it's found early unless they can remove the tumor completely by surgery and there haven't been any metastases. So that's pretty much it. I mean, you're familiar with staging and metastases. And then genetic, so there's a genetic risk for lung cancer, but then most people are either active smokers or passive secondhand smokers. And then chronic exposure to known irritants causes cancer as well. All right, on page 576, 577, 578, 579, we're talking about surgery, surgical management, chest tubes, sternotomies, different incisions. I would just read through that, make sure you understand kind of the different terms and vocabulary being used. Make sure you watch the video that I put on there about the chest tubes. So there's two places where we typically put a chest tube. One is on the anterior aspect of the chest, so the front of the chest, mid-clavicular line, so halfway between the sternum and the shoulder, between the second or third intercostal space, over the top of the rib. So, you know, basically right above the breast tissue, either on the right or the left side, whichever side is affected, on the front of the chest. So that oftentimes is used to drain air. And then if there's you know, blood, or if they need a chest tube for a longer period of time, like a mucus, whatever, then we can place also a chest tube in the 5th or 6th intercostal space on the mid-axillary line. And the picture in your book, I think, is a little confusing. So that top picture would actually be more towards the front, and then that bottom picture would actually be up 1 or 2 ribs. So 5th or 6th intercostal space, so between the ribs, the mid-axillary line. And you know, you could Google chest tube insertion, or I think I put a video up about chest tube insertion, but they're pretty cool to watch the chest tubes go in. So you know, you don't necessarily feel like a pop or a whoosh or anything like that when you put them in. If there's a lot of blood in there, you might have a lot of blood come out when you first put them in. That's fine. But just remember, as soon as you get that tube in there, you've now created air that can go in and out of the pleural space. So you have to get them hooked up to the chest tube, like the water seal, the Pleurovac, the Hemovac, whatever system that you're using. There's Atrium, there's a bunch of different systems, so whichever one you're using. Remember, there's 3 chambers, so if the patient is over here, pretend that those are their arms. My chest tube is going to run from the patient to my machine, right? And the first collection chamber often actually has 2 sections, and sometimes even 3. And so the blood is going to collect in here. So it's draining from the patient through the chest tube into here. And then the second section is called the water seal. Okay, and it's really important that there's at least 2 centimeters of water high in the bottom of the water seal chamber. Okay, so a minimum of 2 centimeters of water is needed to prevent air from flowing backward into the patient. So you have to check the water level every shift. We use sterile water, not normal saline, in the chest tube setup. Okay, so make sure you know where the bottles of sterile water are. And you need a big, like 1 to 2 liter bottle of sterile water. Okay, and then the third part here is the suction control, and that's hooked then to the wall, you know, like a suction canister or whatever, and that is set depending on your policies or whatever, but you don't want vigorous bubbling, so you know, usually we set it fairly low, but in here you want 20 centimeters of water usually. So 20 centimeters of water pressure here, so even when it's disconnected from the wall, there's still basically a 20 centimeter negative pressure, and 2 in here, and then blood there. And then these are connected, so there's like little overflow tubes this way. So if this fills up, if this first tank fills up, you're going to either have to change it, which some new systems allow, or change out the entire suction unit, which the old systems required. We don't strip the chest tube, so you don't milk it. Well, yeah, no, we don't really milk it either, but you don't strip it, so you don't like hold it and pinch it and try to push the blood down through it. There's a great checklist or kind of best practices review on page 579, and I would just suggest that you read through that as well as watching those videos. Okay, so that's important as well. It talks about when to immediately notify the provider and stuff like that. Here's just another picture. So you see this is the part coming from the patient. Then this is the water seal itself. And it has to have at least 2 in there. Right, and then this is the suction control, and usually it's at a minimum of 20. So we set most of ours to 20, and a water seal of at least 2. And then this is the air leak meter, which is kind of cool on this Plurivac. Not all systems have this. If there's vigorous bubbling in here, in the water seal compartment, if you have vigorous bubbling, you have a leak on the patient's side. So it's not normal to have vigorous bubbling in the water seal part. You can have some bubbling in the suction control chamber, that's fine. You can have gentle bubbling in the suction control chamber, and you can have tidling in this area right here in the water seal. So as the person breathes in and out, that level moves up and down. Oh, there's 2. The level moves up and down, up and down, up and down, and that's fine. Okay, that's normal. But you shouldn't see vigorous bubbling ever in the water seal area. That means that you have a leak on the patient's side and air is making it through into the water seal area. Okay, watch those videos.